Welcome to the Psych Curious channel. We're delighted to have you with us today as we embark on an enlightening exploration into the realm of bipolar disorders. Ever pondered over the intricate subtleties of bipolar 1 and bipolar 2 disorders? We're here to guide you on this fascinating journey, specifically focusing on these two distinct classifications of bipolar disorder. Far from being a simple monolithic concept, bipolar disorder represents a broad umbrella enveloping a myriad of related conditions, with bipolar 1 and bipolar 2 being among the most prominent. As we delve deeper into this fascinating topic, don't forget to hit the like button if you enjoy content and subscribe to stay updated on our latest videos. Understanding the distinctions between these two psychiatric disorders is absolutely vital. What exactly do they signify? How do their trajectories intersect and diverge? What symptoms stand apart? Each variant of bipolar disorder, while sharing a common foundation, exhibits unique characteristics that set it apart. As we delve deeper into the core of this fascinating topic, we aim to shed light on these questions and more. Bipolar disorder, at its core, is a neurological disturbance that has profound implications on an individual's emotional state, energy levels, daily activities, and their ability to carry out ordinary tasks. These aspects of life undergo dramatic and anomalous transformations, providing a glimpse into the severity of this disorder. The two main variants, bipolar 1 and bipolar 2, each represent a different facet of this disorder, characterized by distinct symptoms, triggers, and treatment approaches. Bipolar 1 disorder is characterized by episodes of intense mood swings, often transitioning from hyperactive or hypomanic states to depressive states. It's also crucial to bear in mind that these severe episodes may be accompanied by hallucinations or delusions, indicating a state of psychosis. On the other hand, bipolar 2 disorder tends to be more subtle, distinguished by hypomanic episodes which are less severe forms of elevated mood, alternating with periods of depression. Nonetheless, both share the common experience of mood fluctuations. Understanding the unique characteristics of each variant of bipolar disorder is indispensable, as it can significantly shape the approach to therapeutic intervention and pharmacological treatment. Knowledge of these disorders also plays a pivotal role in dismantling stigmas associated with mental health. Despite their shared nomenclature and certain overlapping symptoms, these two conditions best liken to siblings with distinctive personalities, rather than identical twins. They both belong to the bipolar spectrum disorders, but their diagnostic criteria, treatment plans, and prognosis significantly differ. The infamous bipolar 1 disorder, the more formidable among its ilk of bipolar maladies, is hallmarked by manic episodes enduring for a bare minimum of 7 days, or manic manifestations so severe they necessitate immediate admittance to a healthcare facility. This disorder transcends transient flickers of joy or sadness. It's rather a profound, overwhelming tidal wave of sentiment that may debilitate completely. It features episodes of heightened exhilaration, colloquially known as mania, and abysmal troughs of depression, casting an individual into a chasm of despair. The manic episodes are typified by abnormal soaring moods and explosive cyclones of energy. These episodes exhibit themselves in a multitude of forms, embodying a state of unyielding hyperactivity. Individuals ensnared in a manic episode may exude excessive elation or enthusiasm, grapple with sleep due to an abrupt surge in vigor, and may face challenges in honing focus due to a barrage of rapid-fire thoughts. Indicators of manic episodes encompass speedy speech, easy distractibility, an inflated sense of self-worth, and a diminished need for slumber. Such individuals might also partake in perilous behaviors like profligate spending, impulsive decision-making, or engaging in hazardous pursuits. In extreme scenarios, these episodes may culminate in delusions or hallucinations, where the individual starts perceiving non-existent entities or adopts groundless beliefs. This could catalyze a precipitous decline in their mental health and holistic well-being. On the diametrically opposed side of the spectrum, there loom phases of severe depression. These depressive episodes are punctuated by all-encompassing feelings of desolation, despair, and a forfeiture of interest or pleasure in activities once cherished. The individual might succumb to fatigue, wrestle with concentration, and, in dire cases, entertain suicidal ideations. Symptoms during a depressive episode may include weight flux and feelings of insignificance. An emblematic illustration of bipolar 1 disorder is the life of illustrious artist Vincent van Gogh, who was diagnosed with the disorder posthumously. His existence and oeuvre strikingly demonstrate the ravages of this ailment. His bursts of intense creativity, mirrored in the vibrancy and emotional profundity of his masterpieces, were often succeeded by bleak episodes of severe depression. His recurrent incarcerations in asylums and his tragic denouement underscore the deleterious effects of this disorder. It is fascinating to note that the alternating periods of creativity and depression form a characterizing trait of bipolar I disorder. The evaluation of bipolar I disorder involves a comprehensive scrutiny of symptoms, personal and hereditary medical antecedents, and a mental status examination. Practitioners may also employ specific rating scales to gauge the severity and trajectory of manic and depressive episodes. The diagnosis hinges on the individual's self-reported experiences, behaviors observed by others, and a mental status examination. Bipolar II disorder, a complex and intricate variant of the overarching bipolar disorder, is delineated by a cyclical pattern of depressive periods punctuated by hypomanic episodes, devoid of the intense manic episodes that are synonymous with bipolar I. This differentiation is not merely noteworthy, but necessitates an in-depth, meticulous exploration. In the throes of bipolar II disorder, the individual traverses through recurring epochs of depression, often hallmarked by profound sensations of melancholy, an engulfing sense of despair, a palpable dearth of vitality, and a pronounced struggle with concentration. These depressive periods may linger for weeks or even months, casting a formidable pall over the individual's aggregate quality of life. Ebbing and flowing among these depressive episodes, one will encounter medically termed hypomanic episodes. These instances bear an uncanny similarity to the manic episodes observed in bipolar I patients. However, they surface in a less drastic form and lack the same duration. During these hypomanic stages, the individual may encounter atypically elevated energy levels, sentiments of euphoria, or intensified irritability. They may also succumb to perilous behaviors or feel an overwhelming impulse to accomplish tasks. These episodes, however, do not reach the severity or disruption of the full-scale mania that pervades bipolar I. Diagnosing bipolar II disorder necessitates a thorough mental health assessment and a detailed scrutiny of medical history. The person must have endured at least one major depressive episode and one hypomanic episode, with a clear absence of a manic episode, which is more severe and enduring than a hypomanic episode. Let us delve into a tangible understanding of this disorder by exploring the personal journey of the esteemed actress, Catherine Zeta-Jones. Her bold honesty regarding her diagnosis with bipolar II has been a beacon of light in the tumultuous storm of this disorder. She has braved the debilitating lows of depressive periods, only to ascend to the exuberant highs of hypomania. These ongoing battles symbolize an emotional tempest akin to a roller coaster ride, a recurrent pattern distressingly familiar to those grappling with bipolar II. Her experiences vacillating between heightened hypomanic states and bouts of depression create a graphic tableau of this condition. Her valiance in publicly chronicling her experiences has illuminated the labyrinthine complexities and the stark realities of contending with bipolar II disorder. You might be intrigued to ask, what truly separates these disorders beyond the superficial observation of symptoms? Let's embark on a journey of deeper understanding and dissect this query. When we probe into the intensity of these conditions, a stark revelation unfolds. Bipolar I, in its monstrous form, typically exhibits symptoms of a more severe degree than its counterpart bipolar II. These symptoms seep into the fabric of a person's existence, leaving a profound, unmistakable mark, and are not just mere shifts in mood. Consider bipolar I disorder for a moment. This ruthless monster is capable of dragging an unsuspecting individual into severe crises, leaving no stone unturned. It does not limit itself to personal liaisons, but also encroaches into professional territories like workplaces or educational sanctums. It's not uncommon for the hapless victims of this disorder to grapple with stormy relationships, endure underperformance at work, or even face the grim specter of academic failure. The ensuing distress can push these individuals to the edge, and in the most extreme scenarios, impel them to ponder over the unthinkable: suicide. Bipolar II, on the other hand, while equally disruptive, tends to unveil itself in a subtler, less visibly destructive manner. It's like a silent storm, causing havoc in an individual's life, its damage often undetectable until it's too late. The symptoms of bipolar may lack the dramatic flair of those of bipolar I, however, they still pack a powerful punch, inflicting significant harm on the sufferer's life. the divergence between these disorders' facade of symptoms and their severity. The therapeutic strategies differ markedly. While both conditions necessitate a cocktail of medication and psychotherapy for effective control, the specific concoctions differ. For bipolar 1, the usual treatment includes a mix of mood stabilizers and antipsychotics, carefully aimed to balance the seesaw of brain chemicals and alleviate psychotic symptoms. For bipolar 2, the treatment strategy generally involves a combination of mood stabilizers and antidepressants. These pharmaceutical allies work in tandem to maintain emotional equilibrium and manage depressive bouts, which are more prominent in bipolar 2. Thus, the difference between the two disorders extends from the manifestation of symptoms to the therapeutic strategies employed. The management of both disorders necessitates a mix of medication and psychotherapy, yet the precise medicinal mixtures differ. Mood stabilizers and antipsychotics are common for bipolar 1, while a blend of mood stabilizers and antidepressants is a standard prescription for bipolar. Indeed, the nomenclature of bipolar 1 and bipolar 2 may lead one to believe that they are siblings of a similar nature. This, however, is a fallacy, as these are two distinct entities of psychiatric disorders, diverging in their symptom severity, occurrence of manic or hypomanic episodes, and the therapeutic methodology employed. Yet, one might wonder, what does this signify in the realm of clinical psychology? Bipolar 1 disorder, often addressed by its alternative moniker, manic depressive disorder, is punctuated by dramatic oscillations in mood. The emotional spectrum stretches from the dismal depths of depression to the frenzied zeniths of mania, often inciting profound disruption in routine existence and potentially signaling the need for hospitalization. A significant point of concern involves mixed episodes, where the characteristics of mania and depression intertwine and coexist. The magnitude and intensity of these episodes are of paramount importance in clinical diagnosis and subsequent therapeutic intervention. The remedial strategy commonly embraces a blend of pharmacological treatment and psychotherapy, aiming to manage the symptoms effectively and preclude the occurrence of manic episodes. In stark contrast, bipolar 2 is hallmarked by a cyclic pattern of depressive episodes interlaced with less severe hypomanic episodes. This milder manifestation of mania, termed as hypomania, sets it apart from bipolar 1 in a clinical context. Although the symptoms may not wreak the same havoc, they nevertheless cast a significant shadow over an individual's life and mental wellness. The remedial strategy for bipolar 2 commonly pivots around psychotherapy to manage depressive and learning adaptive mechanisms to cope with hypomanic episodes. The distinctions drawn between these two variants of bipolar disorders are far from mere academic discourse. Within the confines of a clinical setting, these dissimilarities bear weighty implications for diagnosis, therapeutic approach, and patient prognosis. Understanding these nuances is paramount in administering appropriate and efficacious treatment, thereby significantly shaping the overall life quality of those grappling with these conditions. As we draw this discussion to a close, we hope that this video has shed light on the stark differences between bipolar 1 and bipolar 2 disorders. We thank you for joining us. Your understanding and awareness can make a significant difference. Now, we'd love to hear from you. Are there other topics you'd like us to delve into? Please leave your suggestions in the comments below. Remember, your curiosity fuels our content. We look forward to continuing this journey of learning together in our next video.